in the framework of the IGF on health implications of the role of internet governance in the age of uncertainty. This is the title of this session. The session aims at discussing roles that digital public policy can have in preserving and improving the global public health, particularly in emergency situations. My name is Patrick Leusch. I'm the head of European Affairs at Director General's Office of Germany's international broadcaster Deutsche Welle, based in Bonn and Germany. The COVID-19 pandemic has shown that the development of digital technology can make our societies maybe more resilient to these global health threats. We have been fast learner in the past months, I think. The whole health community, but also citizens, have adopted to very new situations, and we have seen grown a lot of digital tools also that could help people and the health system to manage this crisis. However, if technologies are accompanied by ineffective digital policies, then these can have detrimental effects on society. So I think we are all on a way to something, and no state on earth, no health system, no operator was really up to see what the digital potential is to manage that pandemic. My guests will exchange views on the role of the internet and digital technologies and what it can have for a role to improve people's health on one hand. Challenges and future of telemedicine is an interesting point, obviously, that goes far beyond this specific pandemic. And local and global stakeholder responses to deployment of digital public policy for public health. These are some of the topics that we will discuss in the next 90 minutes. Here is the leading question for that session. Could digital be the key to achieving sustainable development goal number 3 of the SDGs, to ensure healthy life and promote well-being for all at all stages, and all this under the impression of the COVID-19 pandemic? So here are our guests. First of all, let me welcome Mrs. Anuradha Gupta, Deputy CEO of the Global Alliance for Vaccines and Immunization, today called Gavi. Thank you very much for being with us. I very much welcome Kira Radinsky. She is Chairwoman and CTO of Diagnostics Robotics in Jerusalem, which she co-founded in 2017. She's an inventor and entrepreneur specializing in predictive data mining. Kira gained some recognition after her software predicted the first in 130 years outbreak of cholera in Cuba. We have among us Mrs. Precious Matoso Malebona. She is director of the Health Regulatory Science Platform at the University of Witwatersrand, South Africa, and also in the World Health Organization, director responsible for the development and implementation of the global strategy and plan of action on public health. We have with us Mr. Bernardo Mariano, Director Digital Health and Innovation and Chief Information Officer at WHO. In this role, he is responsible for coordinating WHO's digital health vision and strategy. Very warm welcome, looking forward to your contribution. And last but not least, we are connected to Dr. Anurag Agrawal. He's director of the CSIR Institute of Genomics and Integrative Biology in New Delhi, India. And he's also a member of the WHO Digital Health Advisory Group. So this is a great panel, and we are looking forward to your insights. While we speak, I'm asking you to mute your microphones and keep your cameras on to guarantee smooth running of these digital sessions. But I assume you all have become, in the meanwhile, experts of this kind of unusual conversation, which turns to be the new normal, it seems. So thank you very much for taking part in this panel. So here, let's start. In recent times, I think we agree all that nothing has challenged the health systems as the COVID-19 pandemic, and many countries were more overwhelmed with a rapidly growing number of infectious cases with high death rates. And we have witnessed the heroic work of medical workers around the world, but also their extortion. It's not surprising that many health systems turned to digital very soon to cover these challenges. Apps were released, databases created or improved, health information systems improved, and the likes. There has been a range of measures that have been taken more or less soon, with more or less power and more or less systematic approach. We have seen how digital technologies have been deployed to help fight the pandemic as a whole. So what is your experience in this regard? How have digital technologies helped so far the health systems in times of the pandemic? Give us an assessment how big is the link and how big is the contribution of digital systems to manage this pandemic? And I'm turning this question to Bernardo Mariano, Director of Digital Health and Innovation and Chief Information Officer of the WHO organization first. Bernardo, please come in. Turn your microphone on and come in.
Thank you, Patrick. Good morning, good afternoon, good evening to everyone, depending on where you are, and happy to be here. Let me just start by saying that we at WHO, we promote the use of digital health technologies, and appropriate use, I have to say. Appropriate use means it should be people-centered, trust-based, privacy and ethical-based, evidence-based, effective, sustainable, inclusive, and equitable, as well as contextualized to where we are using that technology. At WHO, I wanted to also say that since the pandemic, we have witnessed a great collaboration across sectors. We had a good support from our traditional partners, other UN agencies such as ITU, but also most important from the private sector. We had a good support from the private sector. But it doesn't need to take a pandemic for us to work in a collaborative way. We should actually have done that earlier. And preparedness is key, because if we had done earlier, we would do much better in this pandemic. Now, what was the experience and how it helped health systems? Let me take you through three areas. One which is the people-centric, the other one which is value add to existing health system, but also how to build a stronger health workforce. So in these three areas, I just want to say that currently we are working with a number of countries, as well as the G20 countries, to look at how we can leverage on telemedicine to support health systems at national, subnational level. The technology is mature enough, but we need to adjust policies and regulations to really leverage on that. So we're working with a number of countries on that. But early in the year, we had a lot of calls from contact tracing as test track and tracing was happening, and digital technology helped there. So at WHO, we published a guideline on a guide on ethical consideration for use of proximity tracking technologies for COVID contact tracing, for instance. This was a topic that our member states, lots of countries were grappling with. How can we make sure that those technologies support the current pandemic? Of course, contact tracing has to be an integral part of public health response, because if it is not, then it doesn't add the value and it doesn't. We don't leverage on that potential that it has. But as part of the pandemic, we also started working with Estonia to develop a digitally enhanced international certificate of vaccination. As we start thinking on vaccination, international certificate of vaccination, which currently is the yellow vaccine card for where some people, especially living in developing countries, where the yellow vaccination card is required. You know very well. Others that perhaps might not know, but this is the only adult vaccination card that is recognized across borders. So we want a digital enhanced vaccination card. We also started piloting a digital clearinghouse to help countries to navigate across the myriad of solutions that are put to them, on innovation and other areas that to try to support and help countries to navigate and manage this pandemic well. The last part, which is the strong health workforce, we fast-tracked the WHO Academy, the launch of a WHO Academy, which is a strong digital component. But also, we added a number of trainings on our Open WHO Academy. So it's openwho.org, which is a learning platform that provides online training in 41 different languages with 17 different topics on COVID, and has currently 4.5 million users benefiting from that. So all to say that we ramped up, we accelerate the use of digital technologies during the pandemic, but we could do better, and we can do better, and we can do much better to prepare for next one. Thank you.
Thank you very much for this first insights, Bernardo. You have mentioned a couple of points, particularly the people-centered, trust-based, inclusive. This is very demanding when you have to cover the world. So, what is the main aspect that you, as a WHO organization, are seeing in this deliverable to people? Is it more to have same standards from technology basis, or is it more to improve the political systems in governing this kind of technologies? You have said the performance of the technology is there, the lack is elsewhere.
Yeah, indeed. Let's recognize that the digital maturity of countries is very important as we look at how do we support countries maturing to the progress. Also, we are witnessing and living a digital transformation of healthcare sector. Within that, each one of us has a role to play, and we have an added value to bring to the table. At WHO, we look at how, for instance, how to address the interoperability challenges that every country has. Health is siloed by tradition. So digital technologies to leverage on them and really use them to accelerate SDG related to health, we need that interoperability to work. So we have the mandate. Yesterday, the member states approved the global strategy on digital health. So within that, we want to make sure that the investments on digital health and maturity of digital health allow countries to move from the current maturity level to the next one. So countries at different stage, but then we issued as well in digital health investment guide, implementation investment guide, so which allow us to say, if your maturity is at this level, the investment should have that path. We want to see the added value a year from now, where that maturity is increased from where it was to where it should be. And if not, so they may take action. So yes, we understand that the countries are in different stage, and we need to work together to ensure that we bring them to that maturity level that we all want. Thank you.
Yes, thank you very much so far. Let me pick one aspect that you mentioned also and jump over to Kira, as you mentioned, that an interesting point here is the collaboration with the private sector that has been obviously boosted by the pandemic from the public health perspective to increase relations with the private sector. Kira, as a chairwoman of a startup, I don't know if startup is correct, but the private company that has been involved very early in the management of the COVID crisis, is there any detection that you have on particularly that link from public health to the private sector, where things have moved forward to become a little bit more speedy, or a little bit more how to say, better the link between the industries?
Right. So first of all, Diagnostic Robotics has been building triage systems for the last 2 years. The way the system worked, they are trained based on historical 76 million historical medical visits obtained from the healthcare system, both in Israel and the United States, with additional 60 billion claim data. The system, what it knows is to ask triage questions and predict the urgency of the patient and where in the medical setting the patient needs to be navigated. The concept was to reduce the routine work doctors were doing for years, if not centuries. And what we've seen, especially during this pandemic, is that the scalability of physicians came to the maximum. In other words, we understand that we cannot continue in the same way we started before. We have a shortage of 100,000 primary care physicians in the United States alone. So we cannot just continue training more doctors and assuming they're going to be enough for the growing population. Until 2030, we're going to have 3.8 billion people without access to primary care. It actually means that the 3.6 hours that people are waiting right now inside emergency departments in the Western world, it's going to be very quickly more than 8 hours. And it's not a prediction, it's just a fact, because in different locations in the world, this is how long patients are waiting. And during COVID, it became even more severe. You have an entire population in crisis that needs to be triaged almost immediately. They need to know where to go to the emergency department, stay at home, lockdown. What should they do? And there is just not enough call centers to answer everybody. And this is where the contact applications come into place. Is this okay to actually monitor people? Or do we actually want to monitor all of them just clinically? So what we started doing is extending our triage service to start automating all of these processes. Every time a person needed any interaction with the healthcare system, our system would ask them a set of triage questions. Predict should they go to the emergency department. If they did, if the system saw in the past that patients like them usually deteriorate, stay at home. But most importantly, predict for the government which cities are in a very bad trend. In other words, give recommendations around differential lockdowns. It was very much at the beginning of the pandemic when we actually deployed the system. It was used as a decision support system at the beginning of knowing where to send COVID tests because we just didn't have enough. During the second wave, it was around differential lockdowns, so we can actually make economy work faster. And I think this collaboration between government and a private sector, where the private sector is providing tools for decision-making, has been accelerated significantly during COVID.
Thank you very much. The question was, I understand clearly that the effect of your work. Have you had the impression that, despite the fact that you have not started working in this sector just with the pandemic, but is there, from your perspective, is there any learning or improvement in the relations between private sector and public sector in that regard?
I think this is a lot that we need to still improve, right? The only thing that a private sector like us can do is provide recommendations. It doesn't mean that the decision maker is going to follow this. They have a lot of political aspects that they need to cover that became so significant during COVID times that it outgrew some of the scientific recommendations done by either the private sector, academic sector, and even the healthcare system as a whole. So here we actually need to think at what time do we want the scientific knowledge to overcome political aspirations? I think this is the main issue that we saw specifically in Israel, that companies have predicted, research have predicted that we're deteriorating, but still no action was taken. Conspiration theories about the fact that, well, there is no COVID, lockdowns do not help. We even have proofs from data showing that interventions of lockdowns significantly caused a lower impact of COVID in certain locations. But still, we as a scientific community need to also think how we clearly communicate with the governmental agencies to give them this information so they can take action. In other words, for example, it wasn't clear if going back to school is actually causing or not deterioration in COVID. Very lately, it was shown that for children under the age of 10, they get COVID 2 times less than adults, but still no study shows how infectious they are. So I still think that we need to supply more information, more with speed, because it will create less trust between the decision-making and the private and research community.
Thank you very much, Kira. I think that is a very interesting point, the relation between politics, science, digital, and relating to trust, because as Bernardo also mentioned, a couple of questions regarding the use of digital technologies for health is really the trust, the trust matter, both from politicians, but also from citizens, to my perspective. Precious, in South Africa, from your perspective, coming back to the question, what is your experience? How digital technologies have been deployed to help fight the pandemic? So, what is your experience in that regard, looking over the last 6 to 8 months?
Well, I thank you very much, and good morning, good afternoon. The South African experience is that we started firstly by having a digital health strategy, and that was important because we had, worked hard to make investments in making sure that the digital platforms were in place, and well, there were a number of challenges, and I would like to start with those. In that, firstly, because we had invested over a number of years, we registered over 43 million patients on our health patient registration system. But it took us quite a while to deploy, the systems across the whole country in all clinics. In fact, we could only deploy this in clinics, not even in hospitals, because of the complexities of the hospital-based systems. So this is the first step that we took over a number of years. But as we're doing this, when COVID hit, we had to look at various digital tools that were already in existence. Like, for instance, we had what we call Mom Connect, based on our mHealth strategy, which was used for antenatal care. And we used this as a platform that was used for information dissemination, in that we sort of develop a number of applications, apps. One was intended for contact tracing. And I always say that contact tracing must not be techno-surveillance, which is a risk that is likely to happen. Secondly, we also had tools that could, for instance, be used for self-screening for COVID-related symptoms. And at a population level, we've had the district health information system. I think it's a system that is used for routine data collection. And it's used, the risk that we've always had over time is that because of a lack of interoperability, we had multiple systems that did not talk to each other. And I think Bernardo referred to this somehow. But I'm happy to say that all these platforms that were developed over the years have actually come in handy, in that we're able to connect all of these. But it is not just tools that are used for the health systems. It's also tools that are used for patients themselves, for citizens themselves, to monitor whether they have COVID or not, so that they do not, come to our facilities when it's a risk to do so. But what is happening is that we've also had other tools, like the ATM pharmacy, that have been rolled across the whole country. And the nice thing about some of these tools that we've developed is that they've actually avoided having people come to the facilities when they don't need to. For instance, for collection of medicines, they don't have to come to facilities. The area that we could have done better and, we could have invested over a number of years is on telemedicine. We have, but it's only in selected areas and areas where I would describe as centers of excellence. They are not widely implemented, and I think it's a lost opportunity. For those facilities that have systems in place, it has been very useful to collect data because we are able to see and track patients and to know how well we are doing on COVID. For instance, the number of hospitalizations, the number of patients that are, positive, and number of patients that have recovered. These systems we've built over time, and we've learned from the experience of HIV and AIDS. As you know, South Africa has a high burden of HIV and AIDS. So those systems have actually been very, very helpful for us. And we've used some of the platforms, for COVID, and we took advantage of that. I just want to raise a few points that I think we need to note. One, there are just too many applications, and the risk is that you then get information overload. Not only information overload, but a risk of misinformation. And this sometimes undermines our efforts to contain and mitigate, COVID. So we need some governance framework so that we can see what kind of apps are out there and regulate them, and whilst promoting innovation. We want innovation, but ensure that it can be trusted and it can be used appropriately and it can benefit society. So one, governance structures are important, but we still have infrastructure problems, as you know. The cost of connectivity is a barrier, and also interoperable digital health systems and solutions. Not all of them are interoperable. So it's one hurdle we have to address. We do have some legal framework, and they are being implemented, and these are intended to deal with data protection, consent to use, privacy, and security. And one thing is to invest in digital skills so that the management of big data and the capacity to do so exists. I thank you.
Thank you very much, Precious. That was very interesting insight. What I take is what you said at the end. You need a digital strategy, you need a legal framework and digital skills. And I think we will come back also to the point you're saying, how can we avoid the information overload, the fact that there is too many applications which we deal, and particularly citizens also deal. I'm taking the opportunity to call on participants in this great session, inspiring session, to put questions or comments in the chat or in the Q&A section that you see in the bottom row below your screen. They are forwarded to me so that we can integrate them further in the discussion. Arunada Gupta, let's have a look a little bit further, going a little bit beyond the pandemic. How could digital innovation help to protect health of our people in more effective, efficient, and accountable manner? We have seen so far, we have looked more in the aspects how to manage the pandemic when it's there, when you have to avoid overload over the health system. That is all related to tracking, for instance, orientating people to the right service, the triage questions we had. But in the more forward-looking terms, how could digital innovation have to protect from people from now?
Yeah, so thank you for that question. Actually, I'm not sure whether everybody's aware that Gavi has a massive scale of operations. So we actually support more than 70 countries in expanding life-saving vaccination to about 80 million children every year. So in the countries that we support, there are 80 million children born every year who need to be vaccinated. And we are looking at about 500 million vaccine shots, that are provided to these children, because they have to be protected against a range of diseases. So clearly, these are big investments and big operations. And some of the speakers actually touched on this whole dimension of a private sector and a private public sector partnership. And Gavi actually was set up at the turn of the millennium in 2000 as a public-private partnership. And the whole idea was to set up a unique alliance that can leverage the comparative advantage of both public sector and private sector. And therefore, we have been able to leverage a lot of innovations in taking immunization to those countries and to those poor households, where it wouldn't have reached without these efforts. And we have indeed exploited digital technology a lot as we have tried to do this. So typically, I like to say that vaccination happens when 3 V's come together. And these 3 V's are the vaccine, vaccinator, and vaccinee. So you need these 3 V's at the same time, because if you don't have vaccine, then you can't vaccinate children. If you don't have vaccinator, vaccination will not happen. And vaccinee is the child who has to be brought, by the caregiver. So really the 3 V's have to come together. And on each of these 3 V's, actually we have exploited a variety of technologies, including digital technologies. For example, on vaccine, we use a lot of digital technology to make sure that we have vaccine logistic management systems, so that we have end-to-end visibility on how these vaccines are traveling, and how stocks are being managed, and really the level of consumption of these vaccines. There are some very interesting innovations that we have done. For example, remote temperature monitoring, and this is, so we have data loggers and we have temperature monitors that are put in the cold chain, which actually start to send digital messages to managers when there are temperature excursions, because vaccines have to be kept at a certain temperature. So if there are temperature excursions, then the potency of vaccines is lost. So when we didn't have these digital technologies, we could actually be vaccinating children but not immunizing them or protecting them, because the vaccine could have lost its potency. So these kind of investments are helping us increase both efficiency and effectiveness of our interventions. Another on vaccinee, for example, one of the biggest breakthroughs is by way of electronic immunization registries, because a lot of these countries that we work in actually have very weak health systems, but they also do not have civil registration of births and deaths. So clearly the denominator is very unclear. What is the target population? The children do not have identities. So therefore, what we are trying to do is to set up electronic registries of immunization, so that the health workers absolutely understand who are the children who have to be systematically reached with different doses of vaccines. In terms of vaccinators, we have invested a lot in scaling up digital technologies for their skills enhancement. Skills are important. And if vaccinators do not have those skills, and particularly as we deploy new vaccines, because there are new precautions and new regimens that vaccinators have to be made aware of. So we have found this extremely convenient to do capacity building at scale in a much more efficient and effective manner. And the last thing is the vaccinee. How do we work with communities and caregivers to spur demand? So we have lack of demand in some settings where the benefits of immunization are not known. So we are using digital technologies, including mobile phones, SMS, and all kinds of things to make sure that caregivers are made increasingly aware of the benefits of immunization. But there's also a lot of misinformation, as you know. And we think that good information is the best antidote to bad information. And therefore, just making sure that we make use of technology to counter false propaganda and rumors.
Mm. Thank you very much. From your perspective, what is the point that have deciders all over the world, when you look at the global scale, learned first when it comes to the link of digital innovation, digital systems, and managing such kind of crisis? What was the first thing really that triggered people?
Yeah, so I really think it is, it is lack of or it is dwindling sort of opportunities to have a physical contact. Because in a pandemic situation where we are increasingly talking about lockdowns and social distancing, people sort of, one of the things that we realized was that there was wide scale disruption of health services in countries that we support. And actually among health services that were disrupted, immunization was the worst hit. And that was because of two reasons primarily, because there were fears among the caregivers. Mothers did not want to bring their children to facilities any longer for immunization, but also the health workers were very fearful of catching infection. They were also redeployed in many cases. So therefore, the whole ecosystem got completely topsy-turvy. And that is, I think, that is what put pressure on the system to start to think very innovatively. And we saw that a lot of digital tools that we have been deploying, but which hadn't been really scaled up, in many cases, actually were really sort of, adopted at a pace and at a scale which is unprecedented.
Thank you very much. Dr. Agrawal, last but not least, same question to you after the intervention of your colleagues, and from your perspective, what is the main point where digital innovation will help in the future to make people more resilient, to make health more efficient to citizens, to people? What is, from your perspective, the main point here?
Thank you, Patrick. I'll take forward on Radha's point, which was a great example of how digital is making something essentially physical, right? I mean, when you vaccinate somebody, there is a human at both ends, and you're giving a vaccine, a physical thing. And digital can enable even that. But there are at least 3 more levels that you can see where digital will change medicine. The next most obvious level is the people are still there. There's still a doctor. There is still a patient. But the medium of communication is entirely digital. That's telemedicine. If you take one level further from that, there is a patient. It's digitally connected, but the person on the other end is not a human being. It could be a chatbot. It could be an algorithm. It could be giving answers. And the last level, which I think we will see very soon, will be digital. The person does not really exist for the healthcare. It's a digital twin. Lots of wearable devices creating a digital image of a person that is continuously being analyzed by digital algorithms. Only when the two find something that is worth communicating to the physical world does the information come to the physical world. Each of these levels is possible. And in the field that I come from, genomics, for example, digital is not optional. It is essential. There is no possible way in which any human being can look at billions of bases of a human being and figure out anything. So the way I see digital transforming health is, number one, in, for example, countries like India. India does not have to be. The number of doctors per 1,000 people is less than 1. WHO recommends 1. If we count all type of doctors, India barely hits 1, but otherwise it's less. Europe, for example, is typically 4. And in most of countries similar to India, the doctors are very unevenly distributed. So you need digital to create the connections. And if you can use your less skilled manpower and upgrade their skills, you don't even need full AI for that, just simple intelligence augmentation algorithms, putting basic guidelines into practice, that can be done. You need smart infrastructure. That's going to change everything. And as we move up the chain, we will see more and more of examples where human comprehension and ability becomes limiting at the cutting edge of medicine. And there will be at least assistance and perhaps at some point a bit of autonomy for digital medical systems. At least in genomics, I can tell you, what we finally practice is what comes out of very strong, rigorously tested pipelines. And this is what we will see in the digital medicine of the future. At some point, we cannot exactly comprehend everything that is done, but we run very rigorous tests to make sure the system works well. We try to make it fast. There is nothing faster than digital. There is nothing more scalable. The most important part is, does it work? And that's something we'll be spending a lot of time on in the time to come, to make sure that we don't get blinded only by the speed and the scale. We also continue to imagine, is it really helping people? And that's something only time will tell. I'll stop here.
Thank you very much. That's really a far beyond outlook that you present here. But I understand instantly that from your perspective, digital can be a solution where it will be very difficult to make sure that the classical services, the classical health services that we know in some countries apply to everyone on Earth. I think that is the background from which you come. How do you see the trust item that we had several times in the discussion here when you deploy this kind of vision?
That is such a phenomenal follow-up question. I think trust is central. When the time comes that algorithms are telling doctors what to do, and will come soon, and doctors not necessarily being known for their mathematical skills are unable to fully comprehend the reason, but they can only see the data showing outcomes and the algorithm works. Trust is going to be central. Patients fundamentally trust doctors, not algorithms. Doctors trust hard quality clinical outcomes, controlled trials. That data needs to be generated. And governance needs to be both lean and balanced. I mean, sometimes you think these words are impossible, but it has to be. You have to figure out a way in which data can grow rapidly. Trust is high within the system for everybody. And the only way that comes is transparency. In my opinion, when everything is transparent, when doctors know the data from the trials, the outcomes they're being shown, every step of it, whether it be by blockchains or by any other methods, non-tampered, original, visible to everybody, then that transparency will bring trust. That trust will bring the progress in the field we all want to see. So transparency at the end.
Thank you very much. Obviously, you are really convinced about the vision that you're presenting. I'm looking at the chat here and the Q&As that coming in that are more and more, and they are pointing to 2 points. One obviously is how to ensure the right to privacy is respected regarding digitalization of health data. I mean, I think that is really a big challenge, and that is a discussion on the whole world. We see it here in Germany. We have had intensive discussion about a simple tracing app, which is completely decentralized. It's not interoperational with other ones, and even here it was difficult to bring it to the people. And the second one is about the link between the public and private ecosystem, because the aspect of commercialization was raised, and I understand when I look at the questions that there is a massive I wouldn't say fear, but there is who is driving it? That is the question. So is the commercial side driving it, or what about government? What about civil society? Who is setting the standards to go forward with digital technology in the health system? Maybe let's pick one by one. I'm turning to Bernardo again, because I think you mentioned that very at the beginning, the privacy issue regarding digitalization of health data. Where's the challenge here, Bernardo?
Thank you. I think So the first challenge really is the fact that digital and health, they're two different, they have two different cultures, right? So you have the culture of monetization of data and the digital tech, and you have the culture of donation. We donate blood, we donate organs in the health, the life science. And to conciliate, I think Anurag was mentioning that, like how we conciliate the two extremes in such a way that we add and we extract the value that both ends can bring, and we bring those benefits that we all want to see. So the privacy and data sharing, it's those are the two or other two extremes where how we can ensure that we extract the benefit of health data for health outcomes, and also we do not harm people, because in health science, life science, do not harm is very enshrined in the culture of medicine, medical doctors, and health specialists. So from our perspective, in what we did and we're doing, we proposed in our global strategy on digital health a framework to regulate for international regulation of health data. It's a framework that we need to put in place that address both the privacy, but also allow the digital technologies to leverage on that data to bring those health benefits we are all looking for, without infringing on privacy or without infringing on ethical consideration. Now, our strategy say people at the center. And to build a trust ecosystem, we need not just a public-private partnership. We need to bring the academia, the civil society. I think there was a question there as well. So there are other stakeholders that need to be in that discussion. At WHO, we're creating what we call a network of networks, because today, and we have a culture, and we have to. I mean, I want to dwell a little bit on this culture, because we are creatures of habits. Now, many institutions were created after the Second World War, and the framework we work it was to address the challenges we had at that time. We have new challenges. We are in digital age. This is the first pandemic in the digital age. So we need new rules, new engagement, new normal. And I think to make sure that there's a trusted ecosystem, we need to bring all these stakeholders together. So the power of WHO is to create a convening element to bring these different entities in the ecosystem and create what we can all trust, be it a framework of regulating health, international health data, or be it a framework to create an interoperability, or others. But we have systems and players that we need to bring together to work in a new normal, and bring players that we normally don't interact with. Even at WHO, our tradition is not interact with private sector. So we had to step up and start that engagement. But the understanding that we have two extremes that we need to negotiate, bring those benefits to the public. Thank you.
Thank you very much, Bernardo. That was very clear. Precious, to your experience, when you started saying the most important thing is that you have a digital health strategy, if I understood correctly, and you base a lot of things that were set up now for the pandemic on the fact that you already had a kind of digital health strategy, which gives you a framework to work on new applications, for instance, to widen the scope. So from your perspective, who are the important stakeholders to design that trust in these applications, particularly from a data protection point of view?
Well, firstly, I think we need to have the most components to be in place. Firstly, we must have a digital health governance that recognizes that digital health is not just for the health sector only. It must involve different ministries, ministries of communication, of health, finance, and also ministries of education. So you need, within that governance framework, to involve different sectors. And secondly, you need to engage different sectors, like we said, public, private, civil society, organization, and academia. But it is not just enough to engage them. It is also to understand, for instance, in South Africa, what we did when we started our work on development of the digital health strategy. We started with e-health strategy and m-health strategy. And whilst we did that, we looked at all the digital tools that were in both the public and the private sector. We came up with a normative framework to assess all the tools, both in the public and private. It was a very useful exercise in that we could see the weaknesses and the strength from both sectors. Those systems that worked, those that didn't, and those that we could build on. So it was a very useful experience. But it's not enough to build systems around patients when you don't involve them. And I agree with Bernardo that whatever systems we develop, they be in the public or private sector, they must put the patient at the center. In fact, I don't say patient because sometimes you're not necessarily sick to use the systems. It is about well-being. So they must be people-centered. People-centered because when you're a patient, you're already sick. So for those who are not sick, but who need to use digital tools, and I think this is an approach that we've been developing. And the digital tools cannot just be for those who work in the health system. We need also digital literacy, so that with this people-centered approach, those who need to use these tools must also have skills to do so. I thank you.
Thank you very much, Precious, for that. Is there something that you want to contribute to? It's an open question to the panel. Any contribution to this thesis that have been deployed here? Kira, I'm looking a little bit to you because particularly the I'm not sure if I'm correct by interpreting the term. As you mentioned, triage. This is something that, from an ethical point of view, can be seen very, 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 very difficult. And we're talking here about how digital systems can take decisions by artificial intelligence. That has been mentioned in a couple of times. So, and that seems for many people very, very unusual and potentially dangerous also. So who is taking the decisions? How are these the systems designed? When I, as a former journalist, I temper to the point.
So very quickly, the concept of clinical triage has been deployed for hundreds of years. So patients should be treated by their urgency. The problem is today how it's being done. It's being done either by set of protocol manually. And this is a lot of the problem in getting healthcare to be streamlined. Knowing which patients need to go where is of an extreme importance for running a healthcare system. I'll give you an example. If everybody goes to the emergency department like they do today, okay, we're not gonna have enough time for patients that are acute. Today, only in the US, there's $200 billion spent on avoidable emergency department visits that could have been handled somewhere else. However, I do agree with you that when developing artificial intelligence systems, and in general, any type of protocol, especially in healthcare, you need to think about fairness. There was a very nice paper published in Science approximately a year and a half ago about the fact that proactive algorithms predicting which patients will deteriorate are unfair to the Afro-American community in the United States. The reason was they were ranked lower is they were receiving less attention from the medical setting in general in the previous years, and the algorithm identified that patients that are costly have a higher probability of doing a preventable inpatient visit in the future. It created a full bias in the way the algorithm does recommendations. So it's a bleeding edge research topic about how to make those algorithms more fair. And I think it's our responsibility as the scientists here to provide systems that are explainable. In other words, there are decision support systems that are not making the decision, and to be as transparent as possible. And there's several mathematical algorithms to actually ensure the fairness across several subgroups while not hurting performance. So I definitely agree that in clinical aspects, you have to understand how to do it correctly. It doesn't mean that we should not do it, because the problem is currently we're losing the fight in a scale. Okay, as Anurag was mentioning, it's unthought of that we're going to have a system running on thousands, billions of data points and thinking a human can actually do it. So we need to change the way we think and move to a more digital world, like we've already done in finance, for example. So why not even in healthcare? It doesn't mean we're not going to have the human touch. It means that we're going to have more human touch, because doctors can actually do more face-to-face meetings instead of doing the administrative work. A few hundred years ago, they were having 200, 400 patients for a primary care physician. Today, it's 2,000, maybe 5,000 in 7 countries. It doesn't scale.
Mm-hmm. Thank you very much, Dr. Agrawal. I'm sure you also have some thoughts about this aspect.
Yeah, I do. I mean, my first thought on privacy is it's a very, very local context. I mean, if you look at the GDPR versions in Europe versus other laws elsewhere, it all depends on how you perceive health data and its use or misuse. The reason for privacy is primarily not one of simple choice. It's one of preventing misuse. And how you go about handling health data to make healthcare systems better, but preventing misuse, is a very dynamic and evolving field. To illustrate the point, if somebody was able to download your data and misuse it, that's clearly a bad idea. However, if your data was to stay secure, but algorithms were able to utilize it to tune themselves, to develop better parameters, nobody actually has lost anything. I think we are at the beginning of an age of computer science where many things that are possible are not fully understood by the public. It is entirely possible for your data to stay on your phone, and by federated learning, for the algorithms that work on the data to get better and better and better, so you get a better experience. There is nothing wrong in it. Similarly, genomes can be downloaded. They can stay in the same place. My institute probably has the largest collection of genomes in the country. We would not want to let people download it fully, because you can always crack a genome back to some degree, to the second relative at the very least, especially in a country like India, where people are very related because of lack of intermingling of communities over 2,000 years. But at the same time, we would want that precision health systems catering to Indians become better, and that's very important. Why? Recently, we did 1,000 genomes for Indians. We discovered 13 million new genetic variants, not described in any genomic data across the world at that point. I assure you, if this kind of a study, 1,000 whole genomes, is done in Africa, you will find another 15 million. The genomic data is very dominated by white Western European data. I mean, I'm counting America as a Western European for this purpose. And yet you must make this data available around the world. It should not simply become a point after you spend a few $1,000 on sequencing somebody, nobody will get to use this data. I think there's a lot more to be said. We must prevent misuse, yes, but we must lock data up so that nobody can use it until the explicit complicated permission. No. I'll stop here for the time being.
Thank you very much. That's a very interesting point, obviously. And I see a very lively debate here in the chat about these questions. There is a question on have there already been cases of ransomware against companies, multilateral organizations, or hospitals and clinics regarding COVID-19 investigations of patient data. That links very practically to how to secure the system. The systems, and then there is also this more ethical discussion about who is taking decisions, and where is the interface between human being and the digital world. I think that that is something that is really to shape for the future, as we see that there is a big potential in digital technology, and at the same time it is entering a space where we didn't expect it maybe so much. It's quite different to use a mobile phone to chat with your friends, your family, or your peers, or to see your doctor only on the mobile phone and sending some data to the doctor for consultation. Anuradha, very short, because I want to move to the next step in the discussion, to look a little bit in the future and to start developing some recommendations, some points that you want to give to the community to deal with that challenges. But one point again on trust. Why you have this experience with vaccination, which implies a direct contact. Tell us very briefly where you see the fact that one must work most if you turn more health services into digital. What is the point to taper to make that work?
Yeah, so I think we have to be very deliberate about how we choose to use digital technologies. And I think the value of human interface also needs to be appreciated. So I think that's the point that was being made by Anurag also, that so whatever we can digitize, we absolutely must, right? For example, we are now doing intelligent dashboards to understand just the functionality of cold chain, right? And to the point that Anurag was making, would you argue that country should not be uploading that data, or would you argue that that data is good for global good, right? So I think that's one debate. But the second is that the trust that communities repose in frontline health workers and their providers should not be underestimated. And therefore, I think that human interface and human intervention will continue to be extremely critical. One thing that I think that hasn't been touched and I is about equity. So we talked about fairness, but I would really want to sort of highlight that if we have to make sure that the digital divide that already exists is not exacerbated, and that the pendulum does not swing to the other end, and we lose sight of the fact that there is highly inequitable access to technology and digital technology, and that if we are serious about SDG, which has a unifying aspiration of leaving no one behind, then that is something that must absolutely be kept in mind. Over.
Thank you very much. That is exactly the point where I wanted to come now. We are not equal in our online. We have discussed that. Systems are quite differently set up in different regions of the world. Roughly half of the planet is still unconnected. Many are not meaningful connected. Most of them in remote areas, often rural areas. In other words, digital technologies are not accessible to all, and often they're not equally accessible. And it seems to me that it builds on a situation that we have seen before, that many vulnerables that have been vulnerable to other conditions are also vulnerable to digital improvement somehow, because that is exactly the groups that we need to connect. Now, here's the question: how to ensure that digital healthcare deliver for all, and how do we make sure that we are not leaving someone behind? I would turn to a very structured approach now and give you one by one again 2 to 3 minutes to give us some very practical point from your standpoint, from your experience, how we have to make sure that digital health innovation delivers for all, and we make sure that no one is left behind. Let's start with Bernardo again.
Thank you, Patrick. I think we some panelists alluded to the issue about what challenge we have in the physical world and the challenges that we have in the digital world. So I think we need, and some leaders are already starting to also discuss and recognize that we need new rules in the digital world, that because of trying to transpond the rules in the physical world to the digital do not necessarily work. And on equity, I wanted to also make sure that we don't forget gender equality in addition to health equity approach, but also accessibility for people with disabilities as we create this digital ecosystem. And from our perspective, and we see it as our role to support countries as they develop those digital health strategies to ensure that those are included. But I think we today, and Anurad mentioned, we have the digital divide. Close to half of the world still don't have access to broadband. So we work, the way we are trying to address that is to ensure that as we promote the use of digital technologies, we also promote the accessibility to those that are not connected by working with the entities that are working on the ground with countries to ensure connectivity. So we have the ITUs, we have the national governments to ensure that and I think even Precious mentioned, it's not just an issue of health, it's an issue of finance, technology. So bringing those entities together to address those multiple challenges, but also understand that we are in the digital world that requires new sets of rules, standards, and framework to ensure that we reap all the benefits. It's at the center of what we have in the global strategy on digital health, where we plan to implement a number of solutions, frameworks, and technologies to ensure that we all reap the benefits that the digital technology can bring. So yes, we are recognizing that the fact that the world is not equal, but also we are recognizing that by working with the countries at all levels, even at community level, because we cannot forget the community health workers that require these skills and knowledge to ensure that we transcend and we create that transformation on digital in such a way that we bring benefits. So working together is key. Working together in a different way than we've been working in the past is very key to ensure that we bring those benefits.
Thank you very much, Bernardo. Precious.
Yes, thank you. We have to address the fulcrum of inequality and inequity. And to do that, we have to reset and reform our health system so that we can meet the challenges of digital health advances. As we do that, it must be with the explicit purpose of improving access and ensuring that regulatory safeguards are in place. Now, in resource-constrained settings, the investments in human capacity development are important. They're important because they need to match this digital revolution. What Anurag was saying, in countries where the basics are needed, we need to ensure that we can benefit from both high-tech technology and the basic day-to-day things that can help us improve access to quality healthcare. So this must ensure that the health system is transformed. The health system as we know it must be transformed in such a way that service delivery is improved. But it must be done in such a way that the users of services are empowered. They're empowered to manage and monitor their own health so that they do not run to health facilities for every small health problem. And if this is the case, it must help us reduce costs and ensure that health is affordable and accessible. But that extension of services is also for the benefit of those who are in remote settings, those that are in rural environments. It cannot be that when you have a particular address, then it's a disadvantage and it doesn't allow you to access healthcare. So your geographic location must no longer be a barrier to access. So we have an opportunity to improve health outcomes and an opportunity to improve the effectiveness of our patient management with these digital decision tools that Rika referred to earlier. Of course, this will improve our targets for the SDGs and SDG in 2030. Thank you.
Thank you very much, Precious. Let me point a little bit on this. Do I understand you correctly that your hope is that with digital technology and if you organize the acceptance and the skills, you can overcome injustice in access to health services? That is your perspective. While when I understand Bernardo correctly, he's fearing a little bit more than that digital-based health services risk to mirror the circumstances that we have in the physical world and are not necessarily overcoming this injustice. Shake your head if I'm correct. There is a risk of mirroring if you are not looking at the whole infrastructure in a country. Anuradha, I'm turning to you now. Which side do you have a little bit more, to Bernardo or to Precious?
Let me say something, here, because we are working a lot on understanding inequities in immunization. Immunization is one of the most equitable interventions among primary health care. And therefore, we have been trying to study why 11 million children in Gavi-supported countries do not receive even a single dose of the most basic vaccine. And for us, that child, and we call that child zero-dose child, is actually an acute marker of inequity. And you would be surprised by what we discovered. What we discovered was that contrary to this popular notion that these children are living in remote areas, it is all about last mile delivery. Actually, a lot of them are living right under the nose of the governments in capitals, in urban slums, right? And a lot of these children actually exist in every village and every town because actually the barriers that are operating, against access to these populations are embedded in poverty. 2 out of 3 zero-dose children live in households that subsist on less than $1.90 a day. So there is a connection between extreme poverty and zero-dose children. Ethnicity is a big barrier, and then gender barriers, because the mother is not educated, mother is not empowered, she doesn't have agency. So there are complex predictors and stratifiers of these inequities. So my first humble plea here is not to synonymize inequities with geographical locations which are difficult to access. Now, the next insight that I would want to share is, therefore, it is possible for us to actually use big data and artificial intelligence to triangulate very complex data sources to understand where exactly these marginalized populations live and what exactly are their latent profiles. Why is it that they're missing all those? So it's not this is not directly linked to a connectivity issue or the challenge of digital divide. We can still use or leverage technologies to improve access for marginalized populations. And the last thing I would say is that, the level of technology that exists in some of the remotest areas that are not connected is highly variable. So, and we really therefore have to think about differentiated and contextualized approaches. For example, in some of the countries, we found that the use of mobile phones, right, and could actually exacerbate the gender divide, because women did not have ownership of mobile phones. Whereas in some other contexts, we found that there was high ownership on the part of women, of mobile phones. So I just think that just retaining that ability to actually study habitation by habitation, community by community, some of the barriers, and then making an intelligent sort of decision about how do we leverage technology would be extremely important.
Mm. Thank you very much, Anuradha. Very good example. Anurag, again, how to ensure digital healthcare delivers for all.
Thanks a lot. I'm going to start with a comment. One of the most precious comments today was made by Precious, and her point was, how do you keep people from unnecessarily visiting healthcare systems? That is absolutely critical in most overloaded systems. In India, the average time for a patient to be seen by a doctor is under 5 minutes. Of that, 50% of time is in prescription refills and basic measurements. You want to extract the maximum value of every time every patient spends with an experienced medical personnel and minimize the wastage of time otherwise. So you must allow people with non-specific complaints to get advice in their own houses conveniently, such that they don't visit doctors. You must enable the system with a sphere of digital public health goods. These have to be built by the government, so they remain low cost. How the government will pay for them is a question I leave for smarter people like Bernardo. On the other hand, after these basic health services are taken care of, and internationally, we have to find models. On top of it, you need the private sector to create the innovative ecosystem for more and more higher quality products. So I see both Bernardo's vision that even in the end, there will be high cost, differentiated products not available for everybody. Whether you stay analog, whether you stay digital, it will not matter. But essential good services should be available to everybody by public digital health goods and a commitment towards making sure that basic medical advice can be given to people without having to leave their houses, without having to waste time in which they could have gone and earned a wage. Huge number of people get into poverty because they're unnecessarily going around all over the place, wasting daily wages and getting answers that could have easily come to their houses. And I'll stop here.
Thank you very much for this contribution, particularly on this human interface that you are mentioning. I can share from Germany that the impression here, when you look at studies, always the relation between patient and doctor, you also see that many visits are, from a health perspective, obsolete. It's more obviously a social thing. So it's more kind of to have contact, which applies obviously to many elderly people that are doing kind of doctor hopping also, and that is filling the waiting rooms, and that is challenging the system. But on the other hand, it's a need. But the question is it the right place to fill that need? Obviously. Thank you very much. A very interesting point, I think. Kira, how to make sure that digital healthcare delivers for all?
Yeah, so I'll touch on several points. One is similar to what I've talked before. There's several algorithmic methods showing that an AI algorithm is fair. But I think let's talk about virtual care. It actually brought the notion of democratization of healthcare. Everybody can get a doctor, no matter where they are, no matter in which home they live, to get the best doctors no matter where they are. The problem is access. Even in virtual care, 75% of the population, even in Western countries, doesn't know they have the possibility of using virtual care. And I'm talking not about poor people. Most people just don't know they can have this. So we need to work a lot about education around this. Maybe this should be part of the education at school. Use virtual care at least once. Know that you have the possibility of using something that's going to change your life dramatically. This is number 2. And number 3 is, again, education, even for physicians. Physicians in different countries have different education times, different training. And I think building decision support systems across all of the data of all of the world in the best institutions and giving access to those decision support systems for physicians during training in other countries is going to help spread the knowledge in a much more equal and fair way.
Thank you very much. That's very clear. So last step in our panel, and I'm asking you to be even more concise that you have been in your contributions so far. Now, when we look at what we have said, what would be the policy message or the concrete action point or recommendation that should come out from that panel when we look at the points that we have discussed before? So I'm really looking at the clock now. You are all very experienced in shaping policy messages or knowing what one should do and what would be the message that comes out of that panel to challenge what we have ahead us, to make match the digital world and the health world for best purpose, for best service for the patient. So what is what you want to see on the document when we close this session here? Anurag, starting with you. You have max 1 minute.
Okay. What I would like to emphasize is digital health is not just usual health done in a digital way. It requires a comprehensive strategy that takes into account local consideration, infrastructure, and goals. And each country should have a national digital health mission suited toward its own preparedness in the digital world and the health needs of its populations. And I'm glad to say India did have a national digital health mission announced this year.
Thank you very much. Very good point. Anuradha.
So I think equity in healthcare delivery has to be our prime focus now, followed by efficiency and accountability. And digital health actually is an enabler. And we have to stay focused on these objectives and then exploit digital health technologies to allocate resources much more prudently and equitably to make sure that we actually leave no one behind and we constantly improve the quality of services that are provided to population at large.
Thank you very much. Kira?
So in addition to all the topics we raised around equality, better collaboration between government and private sector, I want to raise the concept of data sharing. I think if on a global level, each government would have shared their data from the medical conclusions they've made, even during the pandemic, we could have saved so many more lives in different countries. I think getting to a point where we have a shared resource, where all researchers can work on the same data, all government have visibility even to other countries, can bring lots of breakthroughs in healthcare and treatment.
Thank you very much, Kira. Very interesting point, I guess. Bernardo, right?
Thank you. I think from a key recommendation will be certainly to reinforce some of what some panelists mentioned is every country should have a digital health strategy. With that strategy, should address a number of issues, including health data interoperability, equity, and all others such as ethical and privacy that was mentioned. So that's first thing. Second, each country needs to understand where the country is in the digital health maturity to ensure that, which is the third part, that the investments are addressing are taking that country maturity from where it is to the next level. So by understanding the maturity of the country in digital health implementation or use of digital technologies, then we can drive the investments into appropriate areas to enhance that maturity. And last but not least is that the digital health or digital ecosystem requires a constant improvement and enhancement. 10 years of digital technology is equal to 60 years of human life. So let's make sure that we do not create strategies that sit there for 10 years and 5 years thinking that it still works. If a country developed a strategy 5 years ago, it needs to develop a new one. Thank you.
Thank you very much, Bernardo. I guess that this strategy must be very agile if I have gained any understanding of change that is occurred by digital in our world. So it's more like, you know, design thinking process than having a 5-year strategy. I fully understand that. Okay, last but not least, Precious.
Yes, we need good digital health governance and improved access. But of course, for that to work, we must invest in human capacity development so that we can match the digital revolution, ensure that we've got a sustainable infrastructure that is expandable and maintainable. It's not good to just say infrastructure. It must be expandable and maintainable. Thank you.
Thank you very much. You made very, very, very clear points, I guess, and I'm looking at what you have said earlier, and I think these 6 recommendations or points that you've raised is really at the key of the challenge. I particularly took in mind a subtopic that or a kind of cross-cutting issue that was skills on all levels, to know more about how digital healthcare, digital systems can work, what they can do. And skills is not only to know to manage them, but also to understand how they work, which is linked to transparency that was mentioned several times. And Anurag also said if the systems are transparent, and I think Kira came in the same point, that is very important. And somebody said digital literacy, which obviously is a challenge in many sectors, but I keep that this is really key when it comes to health, because as Bernardo said, we are bringing together here 2 very different cultures, when he said that on one hand the health very much is based on relations between humans, and on the other hand you have the digital world, and he described how far from culture they are from each other. That was for me a very interesting point when he said that is something that we barely need to address, how we make that match for any operator, for any people that is dealing with it, be it in the role of a doctor or a physician, of a scientist, or in the role of a patient, and even in the role of governance. I would like to thank you very, very much for that very, very inspiring high-level panel. Thank you very much for your time, for your contributions. All this is recorded and will stay on the YouTube channel of the IGF on the UN Web TV, so far I understand. You also can follow the chat. Thank you all for your questions, your remarks that are in the chat. Some of them we could pick them, others are self-explaining and interesting to see, because you can see what people think about this very, very complex topic. I would like to thank the organizer, the team behind it, Anja, Kwok, and others. And have a great day wherever you are. And I hope that the next IGF, despite the fact that this is very interesting format, I really hope that the physical aspect will not completely drop out in this pandemic, after this pandemic, and we will have the chance to meet in person and discuss this further, as we will keep really this topic will really be kept on the agenda. Thank you very much.
Thank you. Thanks a lot.
Thank you.
Thank you.
Thank you, everyone.
Thank you and goodbye.
Bye.
Thank you very much.
Bye.
Have a great day.
You too.